can't say that I actually ever remember the time that I made a conscious decision to want to go into medicine. The decision to go to medical school was kind of made for me by the priests at the school that I was studying at, which was St Mary's Roman Catholic Grammar School in Sidcup in Kent. And you know, I happened to be one of the more academically gifted children in the school, and usually what happened was that the boys who were in that particular class were sent off to study medicine or law, or were put onto what was called an Oxbridge track. So I didn't want to leave London. I wanted to stay in London, didn't want to go up to Oxford or Cambridge, and it was decided for me that I would go and study medicine. And I enjoyed science, and I thought you know, a large part of medicine does involve scientific forms of thought, that I would also enjoy medicine. So I started medical school in London. I was at the Royal Free Hospital School of Medicine, which is in Hampstead, which is a really bucolic part of northwest London. And I started medical school there at the age of 18 in 1983. And in the UK, there's no requirement to go to college before going to medical school. Children normally go straight from high school to medical school, which is what I did. And it was a 5-year program. It was 2 years of basic science and 3 years of clinical medicine. And during the basic science period, I studied anatomy, physiology, biochemistry, epidemiology, other basic sciences. And then the last 3 years were spent in clinical rotations, both medical and surgical. And I completed medical school, graduated in July 1988. But in England, the degree that's conferred by the medical schools is known as a Bachelor of Medicine and a Bachelor of Surgery. So it's abbreviated. It stands as MB.BS. So I was awarded the MBBS, and I was awarded that degree in July 1988. And then, as is the custom in the United Kingdom, there's a 1-year post-graduation year that each medical student will go through, and it involves 6 months of working and training in a medical unit and 6 months of working and training in a surgical unit. And I performed my 6 months of medical training at the Royal Free Hospital, which is in Hampstead, on the academic liver unit, which was and is world famous for liver medicine, hepatology. And the subsequent 6 months of surgical training, I undertook that in general surgery and orthopaedics at the Lister Hospital, which is in Stevenage, Hertfordshire, which is about 30 miles north of London. I finished that postgraduate year in July of 1989, and then I first came to the United States in September of 1989, and I was in the US from September 1989 to August 1995. And during this period, I underwent a combination of training in general surgery, anesthesiology, and interventional pain. And it was actually during my interventional pain rotation that I became interested in it and in undertaking further training. I enjoyed the hands-on part of the training. I enjoyed the use of fluoroscopic guidance and interpretation. So when I returned to England in 1995, and I had to go back to the UK.
Well, before you went back to the UK, the training, exactly what were you certified in when it becomes to the minimally invasive and interventional pain?
Yeah.
And where was that from?
Well, yeah, I mean, as far as the evolution of spine is concerned, around about that time, which was the early to mid-90s, interventional pain and minimally invasive spine was, or the skills necessary for the performance of minimally invasive spine were just beginning to come into the medical mainstream. They were still kind of like on the peripheral fringe for a while. But the key technological advance that, in my opinion, was significant in advancing this part of medicine was the development of the fluoroscope, which is a portable X-ray machine. It's also known as a C-arm because that's the way that the machine is configured, as a C. And what it does, is to allow the physician, the interventional pain physician or the radiologist, to image parts of the body. And in my particular training, it was used to image parts of the spine. And we would do this so that we could place needles into and around the spine in a safer fashion. Prior to the development of the fluoroscopic C-arm, most pain management or most injections into the spine for the purposes of the diagnosis or treatment of pain had been carried out in a blind fashion. And when I say blind, I mean without the use of X-ray. So you would use just anatomical landmarks, and there would be a greater degree of estimation of where to place the needle. What the C-arm did was it allowed the needle to be placed with a greater degree of safety, and it allowed the procedure, whether it was the injecting of pain-relieving corticosteroids, to be more effective, because the needle was actually placed in the part of the spine where it was meant to be.
Now, do they train people in this in the United States currently?
They do, and fluoroscopic guidance and interpretation and the training in fluoroscopic guidance and interpretation is a major part of interventional pain and minimally invasive spine surgical programs. And in fact, fluoroscopic guidance and interpretation, in my opinion, is the crux and the foundation of minimally invasive spine surgery. And although it was the interventional pain physicians and the interventional radiologists that were the ones that were principally trained in this technique, it is now also orthopedic surgeons and some neurosurgeons that are beginning to acquire some of these skills. And you know, when one thinks about spinal technique and the treatment of spinal conditions, and you know what's happened to those techniques over the last 10 to 15 years, very simply, they've gone from being very open, aggressive procedures to minimally invasive, fluoroscopically guided procedures, which is exactly what has happened in many other areas of medicine, in, for example, cardiology, in, for example, vascular procedures, in, for example, gastrointestinal procedures. But spine seems to have been, or is, I suppose, what they would refer to as the last frontier in terms of this minimally invasive technology taking foot. When one looks at the history of medicine and you look at innovations, they are always met with fierce resistance when they first become a part of clinical practice. But I can say that with spinal intervention, the less cutting of muscles and bones and tissues, the less blood loss that one needs to effectuate on the patient to perform the procedure, the better. So when I first started to carry out interventional pain procedures, I recognized that what the fluoroscope allowed me to do was to place medications and to do things to parts of the spine that only, or previously, could only be gotten to with very aggressive incisions and dissections. After I left the States and went back to England, I went back and I did an extra year's training in interventional pain at the Bristol Royal Infirmary
2005.
in 1996. And then I was in London up until 2001. And then when I came back to the States in 2001, that's when I began to really recognise the value of my skills in using fluoroscopic guidance and interpretation in the emerging field of minimally invasive spine surgery. Because with minimally invasive spine surgery, it's all about fluoroscopic guidance and interpretation. 95% of the procedure depends upon the accurate placement of needles, probes, instruments, scopes into and around the right part of the spine. And I started to, around about that time, 2001, 2002, start to travel the States and the world, training with physicians and surgeons who I consider to be pioneers in the field, who recognized that this in fact was where spine surgery was heading, that this in fact was better for patients because it didn't require aggressive incisions, it didn't require significant blood loss, extended hospital stays, which themselves have always been associated with a much higher risk of infection. And one of the key things with procedures, and I think it's now been recognized in the US, is that the quicker you can get a patient into and out of a clinical facility, the better. That lowers the incidence of what's referred to as nosocomial or hospital-acquired infections, which, when you're placing hardware such as screws and rods into a patient's back, can be disastrous. So my training and the recognition of all of the benefits of the minimally invasive approach really began to pick up about 2002, 2003, and it continued up until 2012, and I would regularly travel to courses both here in the US, overseas. I would teach at courses, and what I also realized and recognized what was happening during this time period was that the types of physicians who were carrying out these procedures was also changing. So whereas at one point, maybe 20 years ago, when somebody needed spine surgery, you would have a neurosurgeon, it would be a neurosurgeon who would do the surgery. But as the techniques changed, as the technologies improved, as fluoroscopic guidance and interpretation became increasingly important, what happened was that the number or the types of physicians performing these procedures changed as well. So with the technology changing, the physician type changed. And I started to see more interventional pain physicians move into this arena and more interventional radiologists, which made sense because these guys were the ones who had been trained to use the fluoroscopic C-arm for fluoroscopic guidance and interpretation. Now, of course, you've got new technologies coming in, and you've got new types of physicians coming in, and then you've got other elements that play into this arena related to the business of medicine, related to professional egos, that led to friction between the different specialities within medicine as to who was trained to do procedures and who wasn't trained to do procedures. And because there weren't any clear guidelines, there weren't any clear standards, none had been established because minimally invasive spine was such a new and recent addition to the medical landscape. Because of this, it led to a lot of legal battles. It led to skirmishes in the media, whereby a physician who maybe wasn't a neurosurgeon who treated a patient and maybe their outcome wasn't optimal was pilloried and vilified. But I think ultimately with advances in medicine, patients themselves are the ultimate deciders of the type of care they want. And patients today in the States and around the world, when they have the option, will increasingly choose a minimally invasive spine surgical option. And interestingly, they also now are initially, when they have neck or back pain, going to see an interventional pain physician or an interventional radiologist. So I think the ultimate beneficiary of all of this is the patient, who will get, in my opinion, better care, and won't have to undergo the necessary or the ravages of spine surgery of previous decades. A lot has been written in the media about various points of my professional life. A lot of journalists on both sides of the Atlantic have written their own version of events that have occurred. But you know, and if I could go back really to the point at which I left the United States to go back to England, it was August 1995. And as I had said earlier, the reason that I had to go back to the UK was because I was in the States on what was called a J1 visa, which was an exchange visitor visa for foreign doctors training in the US. So one of the conditions of the visa was that the trainee would need to go back to their country of origin for a period of at least 2 years before they would be allowed to come back to the States. So my plan was to go back to do the year of training in Bristol, at the Bristol Royal Infirmary, and then I was going to go on to Sydney, actually, to spend a year training at the University of Sydney, New South Wales. But, you know, as circumstances happened, I met someone in my first year and decided, I became involved in a relationship, and I decided that I wanted to stay on in England for a few more years. So it was I was advised by one of the consultants at the hospital that if I was going to stay in England, that I should apply to the Royal College of Anaesthetists to have my name included on what was called a specialist register. And being on this register would have allowed me to obtain certain privileges from insurance companies and to obtain certain hospital privileges. So I submitted my application to the Royal College of Anaesthetists, and about 6 weeks later I received a response saying that in their opinion they considered my American training inadequate for the British system, and that the American board certification which I had attained, they did not deem that to be equivalent to the fellowship of the Royal College of Anaesthetists. And some people say, well, you know, you should have gone on and either just gone back to the States or done the training in the UK. But at that point I felt that their assessment of it was incorrect and wrong, and I didn't agree with what they had said. I thought that my training in America was equivalent to that of a British trainee, and that my board certification was equivalent to that of the fellowship of the Royal College of Anaesthetists. And so I decided to appeal this decision. And because this was the first time that a foreign graduate was appealing such a decision, it attracted a significant amount of media attention. And I suppose this was the first time that I began to get attention from the media. At that time, initially, I suppose, in a kind of a supportive and helpful way. Anyway, the appeal and my battle with the Royal College generated a significant amount of press attention. It became a very contentious affair because the gentleman who was the head of the Royal College and the Royal College didn't take kindly to the fact that their decision was being appealed. The appeal took place in February 1999. It lasted about, actually the appeal was about 3 or 4 days. About a month later, their decision came back, and they upheld the decision of the Royal College of Anaesthetists, stating that my American training was not adequate to British training, that my American board certification was not equivalent to the British fellowship exam, and that I would need to undergo a further 18 months of training. So at this point, actually, I then decided to return to the States, and so I started to reactivate my paperwork in America and was planning on returning to New York. And about a month after this appeal had taken place, I was involved in a case in London at a dental clinic in which I was administering some intravenous sedation to a 57-year-old patient from Sierra Leone. It was about a 17-minute long procedure, and everything was fine during the procedure. The patient had her wisdom teeth extracted. In the British press at the time, they reported that I had supposedly told a nurse to turn off a monitor and that I had been on a mobile phone. Well, I wasn't on a mobile phone. During the case, we had an engineer come to court who produced a report and he testified that no mobile phone was being used. And the part reported in the media about me telling the nurse to silence the monitor was inaccurate as well. What actually was going on was that the patient, Miss Bangura, you can use her name because it's in the press, she had what's called a pulse oximeter, which is an oxygen monitor on her left hand. And during the procedure, as the dentist was injecting the local anaesthetic, she would move her finger. And as she moved her finger, it would set off an alarm. And it was that alarm that I told the nurse to silence, and not the pulse indicating the oxygen level that was coming from the monitor. But again, this detail was misreported by the press. But anyway, to cut a long story short, at the end of this procedure, this patient had a cardiac arrest. She was successfully resuscitated, and she was transferred to the local hospital, which happened to be the hospital where Professor Strunin was the chief. He then called the police, and in the United Kingdom they have a very different medico-legal system to that in the States. If a patient has an adverse outcome or dies in the UK, the physician can be prosecuted through the criminal justice system. And this is exactly what happened with me. This case became a high-profile case, I think principally because of my battle with the Royal College prior to this. And when I went to trial, there was a lot of press coverage around the case. It was a 4-week trial. At the end of the trial, the jury could not come to a unanimous verdict. And so again, as is uniquely British, the judge and courts can convict using what to call majority verdicts, and that's exactly what happened in my case. At the end of the case, the judge didn't send me to jail and decided to let me go. I then came back to the States in September 2001, and when the press, today, whether it's the British or the American press, characterize me as running away, I feel that that's an unfair characterization, because I wasn't running away. What actually happened is, after the case had finished, I had to pick up the pieces of my life. I just gone through a very traumatic legal proceeding in the UK. I had lost my license in the UK, and every day I feel remorse and sadness about the demise of Miss Bangura, but I still to this day don't know what the cause of her cardiac arrest was, whether it was a pre-existing hypokalemic or low potassium level, or whether it was an issue with oxygen. I don't know. And so I have every day since her demise thought about her, and I feel bad for her and her family. But I wasn't running away from those circumstances. I was simply thinking about what I was going to do with the rest of my life. I was 36 at the time, and I had some connections and had some training in the States, and so for me it seemed like the logical place to go. And I came back to the United States thinking that I would be able to hopefully put the incident in the UK behind me and move on and try and build my life up again and try and continue to use my skills in education to help people. You know, after having come back to the United States in September 2001, I initially came back and I joined an anaesthesia group at one of the hospitals in New Jersey. And my job duties at that first job were between providing anaesthesia in the operating room and working in the interventional pain clinic. And then progressively I began to spend more time in the interventional pain clinic, and I moved from one hospital to another, and then eventually I moved into private practice, and that was in 2003, 2004. And that's also when I started to obtain a lot more training both here in the States and overseas in the emerging field of minimally invasive spine surgery. And as I developed the practice, and as I developed a referral base, I developed a reputation for performing good work. I continued to develop and grow the practice. More and more people were being referred to me, and I was treating them and helping a lot of people with debilitating back and neck conditions using these advanced interventional pain and minimally invasive techniques such as discectomies and fusions. And after having attended one course back in 2004, I recognized that there was a way to perform a procedure. It's called a lumbar interbody fusion, but I recognized that there was a way to perform this in a percutaneous or minimally invasive fashion. And so one of the centers at which I was properly credentialed and licensed to work allowed me to perform this type of surgery, which I did successfully. And I was the first physician to perform what's called an outpatient lumbar interbody fusion. And from that point on, I started to use my skills and my training to treat and help patients who had painful lumbar spinal conditions using these percutaneous and minimally invasive techniques. From 2004 to 2009, I would use a number of surgical centres in the state of New Jersey, all of which had credentialed me, all of which recognised my training and expertise, and all of which gave me the necessary privileges to perform these types of procedures. But then I decided that I wanted to move towards opening up my own centre in which I could focus all of my attention and energy and resources on a centre that was just devoted entirely to minimally invasive spine surgery. And so in 2008, 2009, I bought a building in Pompton Lakes, New Jersey, and I commenced the application process with the state, with Medicare, and with one of the accrediting organisations to have the building converted into a Medicare certified AAA accredited facility. And obtaining Medicare certification for a surgical facility in the States is the highest form of certification, and I wanted that for my facility. And so when I bought the building and started to make the conversions, I also retained a team of clinical consultants, lawyers and architects who came together and developed plans to create a facility that I felt would be a state-of-the-art facility and that would meet Medicare requirements for certification. And in March 2011, after 2 years of construction, the surgical centre in Pompton Lakes, which was known as New Jersey Spine and Rehabilitation Surgical Centre, opened and performed its first case. As I was developing and building the centre, I also wanted to make sure that the facility was or contained the latest and most technologically advanced equipment, which it did. And so I spent, the company spent a lot of money in the investment in the operating room. And the operating room on its own cost approximately $800,000 in terms of construction and the purchasing of tables, anesthesia machines, fluoroscopic C-arms, overhead beams, surgical equipment. So it was I would say it was a big venture, but it was a very natural one for me. It was a very natural evolution to to go from building up a surgical practice, which I did over a period of 8 years, to then opening up a surgical centre, which I did in March 2011. You know, the Spine Africa project, which is a 501c3 US-based charity. I created the charity in 2008 after an unplanned visit to the Democratic Republic of the Congo. But kind of more interestingly, actually, and when people talk to me about the charity, is, you know, people say, well, first of all, you know, why the Congo? And, you know, I really don't have an answer. It just happened to be a place that I was invited to by a friend. But also people ask me why get involved in philanthropic causes and why get involved in giving back. And I'd always felt very grateful for certain things that had happened in my life. And, you know, when I came back from England to the States in 2001, I was broke. I was, you know, I think actually I had about $150 left, but I was starting at the beginning again. And as I became more successful in my practice and material things began to come into my life, you know, for me, I used to have these discussions with myself about, you know, the fact that I had this money and I had these things, and, you know, really what can I do to help other people, both in the States and around the world, with these resources. So when I was in the Democratic Republic of the Congo, and I was given the opportunity to take a tour of one of the government clinics, and noticed the high incidence of spinal injuries, that's when the idea for the Spine Africa project came to me, because I realised that I could bring my skills and my expertise and my knowledge, but also my resources and the money that I had to actually create something that was going to make a difference. And that's when the charity commenced, and between then and 2012, several visits were made by myself and other people to the Democratic Republic, or the DRC, principally to help people who had back problems, who had back pain or who had back injuries. And I can say that that's been some of the most gratifying work for me over the last 10 years, with the trips to the DRC, where most of the patients that we saw had absolutely nothing. I mean, they would come in and they were really on their last legs, literally, some of them. And it was a great thing. It was very touching for me and for the people that I went out there with, to see the difference that we were able to make in their lives with a relatively small amount. And so that personally for me, that was one of the most compelling reasons for the continuation of the project, was that with a relatively small amount of material input that I'd been fortunate enough to gain in the US, I could help significantly people in a part of the world who had nothing. You know, I think in life, I think that people's experiences and what they go through personally are significant, or have a significant impact in moulding what that person then does with his or her life. And, you know, in my life, I've gone through various points in my childhood and young adulthood. I've gone through great periods of deprivation and loss. I've also been very fortunate to have been given a set of skills and abilities that have allowed me to build up a life for myself in America that maybe a lot of other people wouldn't have had the opportunity to do so. So going to Africa and taking my physical self and my time and my knowledge to a part of the world that is, you know, was then and still is one of the most violent areas of the world, to put my physical self into harm's way, for me, came more from my experiences of times in my life where I had nothing and I had people help me. And so, you know, when those acts of generosity were bestowed upon me, I always remember thinking, you know, I can never maybe give this thing back to this particular person who helped me at this particular time, but what I can do is I can continue their generosity at a later point in my life when I have the ability to do so. And that's what the Spine Africa project and what I was able to do for me was the manifestation of it. It was, you know, and although I was going to a part of the world and helping people and using what I had to improve people's lives, it was also a continuation of my own journey as well. That, you know, here I was, that I had grown up with nothing in England, that I'd gone through some very taxing and trying times in my life, where I didn't know what was going to happen. But at those points in my life, there had always been people that had helped me, and I never forgot that. I never forgot that, you know, going through challenges and hurdles, that people never go through it alone. That it's always, you know, that you always need the help of others. You can't do it on your own. And I always remembered that. And so, if you know, when I really think about it, it was that that was the, I would say, the deeper undercurrents of the Spine Africa project. I mean, the fact that I happened to have knowledge and experience in spine was great, because there was a need for that in that part of the world. And the fact that I happened to be in a financial situation where I was lucky enough to have money to be able to buy equipment, to be able to buy materials, to be able to organise the shipment of these materials to that part of the world, because it's, you know, it's also a complicated logistics effort to be able to organise things getting from A to B, but particularly in a part of the world where you're not too sure about safety and you're not too sure about security, and they speak a different language. There's nothing more important to a person than their health, but within that and next to that is education, and that's the key. And for me, that's the key to a person's freedom in all respects. It was for me. You know, when I think back to my childhood and where I grew up, you know, I was fortunate enough to go to a school where the priests really focused on a rigorous education and academic excellence, and that was the path, and that was the key that allowed me to get into medical school and to not go down the wrong road, which happened to a lot of other young boys who lived on the same council estate that I lived on in southeast London. And I think that, again, the education, which is one of the components of the Spine Africa project, is, I think, the greatest gift that can be given to young boys in parts of the world where they have nothing else. Because with an education, you know, it's kind of a cliche, but I'm going to, you know, use the cliche. It's something that no one can ever take away from you. Everything else can be gained or lost, but an individual's education can never be taken away. You know, whenever anyone hears or reads information that is untruthful about their character or their professional standing, it's always an unpleasant and sometimes a painful thing to hear. You know, that goes without question. I mean, nobody likes to read nasty things written about them, particularly when they're not true, and particularly when they really are not based in fact. And you know, the case that I've been going through with the New Jersey Medical Board with regards to my qualifications and training in the field of minimally invasive spine surgery, I think that information has been reported in a very distorted fashion by some of the New Jersey press with allegations that I'm not adequately trained or that I'm not qualified. Well, the facts are contrary really to what the New Jersey Medical Board has said and to what the press has reported. I went to medical school in London and I graduated. I underwent postgraduate training in the States and in the UK in the fields of general surgery, anesthesiology and interventional pain. And then from 2001 to 2002, I underwent extensive postgraduate training in the field of minimally invasive spine surgery. And all of this information is contained in my curriculum vitae and is supported by documents testifying to my certifications and diplomas as to the particular courses that I took. And I suppose what I find upsetting at times is that when we had the hearing here in New Jersey in the Office of Administrative Law, I testified extensively as to my training, and I testified in detail. I went into very clear, specific detail as to what each block of training entailed, particularly with the minimally invasive spine surgery. So I think that when I hear or read that I'm not properly trained or qualified, I do find it to be upsetting. I think it's an outright lie. I think that there is no question, if you look at my CV and you look at my credentials and my training and my diplomas, when anyone takes the time to look at that, which is posted on my website, it's clear that I am more than qualified to perform minimally invasive spine surgery and have been doing so successfully for the last 10 years. So to read the stories that have come out recently making these claims, I find incredulous. I think that many people, both here in the US and around the world, in the healthcare sector and people not in the healthcare sector, have been following my story for one reason or the other. And I can understand why anyone looking at it from the outside, without really understanding the sort of the underbelly of this beast, would come to the conclusion, oh, look, he's doing procedures and he's not properly trained, and that's the end of that. But it's a much more complicated situation than that. In New Jersey, in America, there is a complex interplay in the state, and there has been actually over the last few years, of medicine, politics and business. And the reason that has occurred is because of money. And in America, politicians, when they're running for political office, they need a lot of money to fill their campaign coffers, because they have to spend a lot of money on TV ads and radio ads so that they get themselves elected. So what they do is they look to individuals, industries where there's a lot of money. And in America, and in New Jersey in particular, there's a lot of money in the healthcare sector. It always has been traditionally. So the politicians will go to the wealthy donors, which in New Jersey are the big hospital corporations and some of the wealthy neurosurgeons, and donations were made. Now, without getting too particular, what happened in my case was that some of the local neurosurgeons made some significant donations to certain politicians, and the expectation was that they would put me out of business. And the reason that the neurosurgeons wanted me out of business was because more and more patients were coming to see me and were coming to my centre. And the reason that they were doing that was because I was helping successfully a lot of people. And I was using minimally invasive spine surgery and its techniques to address people's back problems. A lot of the older neurosurgeons had not been trained and were not able to perform these types of procedures. So instead of going and getting the training and becoming proficient themselves, it was easier, in my opinion, for them to kind of get involved in the politics and business, give some money to some politicians, and stop myself from performing these procedures. So I think that the perception of me and my case to people who aren't on the inside of what's going on is that, oh yeah, he's an unqualified doctor performing procedures that he shouldn't be doing, yes, the medical board should stop him. And I can see why people would come to that conclusion, because that's that's what some of the press is communicating, and that's the knowledge, or the limited knowledge that they have. But the truth of the matter is that for many years in New Jersey I had been performing minimally invasive spine surgery. I'd been doing it well, I'd been helping a lot of people, and over this time period of about 8 to 9 years, I'd performed 800 minimally invasive spine surgical procedures. And one of the, one of the strands of my own personal philosophy, which again goes to my own personal experiences as I was growing up. I think it's a lot of people who don't know me and don't know anything about my life have the misunderstanding that I grew up with a silver spoon in my mouth. And that's the furthest thing from the truth. I didn't. I grew up in an extremely deprived circumstances. My parents died when I was young, and I was on my own since I was 16. So I've always felt an empathy for people who are having very difficult times themselves, and that's stayed with me throughout my life, wherever I've gone, whatever I've done. And it's something that was a big part of my practice, that people who came to see me who had no health insurance, and there were a good number that came in because nobody else would see them, I would treat these patients and did treat them for free. And in America that seems to be something that is an ongoing issue before the introduction of the Affordable Health Care Act. But there were a lot of patients who had no health insurance, and I took these patients on, and I treated them, and I gave them the same care that I gave to patients who had insurance. So it was never for me. It was never for me an issue of money or who could pay or couldn't pay. It was an issue of how can I help these people that come to see me that have got these back problems, and that was, I think, to some extent, one of the issues that also irked some of my local competitors, because people were talking in very positive terms about me and about the practice. I can say the last couple of years dealing with the legal battles with the New Jersey Medical Board have taken me away from one of my real passions, which is the Spine Africa project. But part of the Spine Africa project that I feel that I haven't been able to focus on, but will be able to focus on now, is the education of young doctors in Africa. Because I think that education for me was the key that allowed me to move away from the difficulties of my youth. And that, I think, is what's going to be the most important thing for young African boys and doctors. That's going to allow them to change their lives and change the lives of others in a positive way. So, people do ask me, what's the next step, and there's a lot of people are curious to know where I'm going to be and what I'm going to be doing. And what I can say generally is that I'm going to continue to use my skills and my education and my training to help others, whether it be through education or whether it be through clinical services. Oh yeah, no, I feel, I feel like I feel the same way about myself as I've always felt. I feel like I'm No, I've always had good intentions. I mean, that's one of the things I always say about myself, is that my intentions in life have always been good. I've made mistakes, as everyone does, but I've learned from my mistakes. But I've always lived my life with good intent in my heart, wanting to help people and wanting to do good things for people. So I mean, every challenge that I've encountered in my life, starting my childhood to the most recent one with the New Jersey Medical Board, you know, I look upon these challenges and experiences as opportunities for growth. You know, we're all people are constantly changing, and I'm constantly changing, and I think that you know, you know, in going through this experience, I don't ever just say, well, it's always someone else's fault. I look at experiences and say, well, what is it about me that is responsible for these situations or circumstances that I'm in? So I take responsibility in that way, and I do ask myself those questions, and sometimes answers will come to me very quickly and very readily, and sometimes they won't, but I always take and am prepared to take that perspective on the situation. But that doesn't mean that I feel bad or any less about myself as a person, because I know that everything that I do and have done with good intention in my heart. So I don't ever go out of my way to intentionally harm another person. I don't. That's just not in my nature. But I also accept and understand that my profession of medicine it's not an exact science, and unfortunately people, the outcomes that people have from clinical care are not always perfect, and of course whenever that happens, I as a person, more or before as a physician, feel bad. I always do. I mean, when Miss Bangura passed away in England, I felt terrible. I felt really terrible, and I do. I think one of the misconceptions that has been perpetuated through the media is that somehow it didn't affect me emotionally, but it did. I was upset, very upset about the fact that she passed away. She was someone's mother. I know how it is, or how it was, to lose a mother. And similarly with the patients that I've taken care of here in New Jersey over the last few years, you know, I should say most of the patients that I've looked after have done very well, and that's been great for me to feel that I've helped people. And yes, of course, there are people who haven't gotten any better, and in some cases some people claim they've got worse. So yeah, I mean, of course, when another human being is experiencing loss or is experiencing pain, I feel bad, I do. So it's not, you know, I feel sometimes it's a bit unfair that the media and the stories have tried to paint me in a very dehumanizing way. And I think, and I understand why they do that. It's an easy and obvious thing to do for the media, to portray or to vilify the doctor. But the truth of the matter is that, you know, before I'm a doctor, I'm a human being, and I feel and experience the same things that patients who are going through loss or pain do as well. So, but I continue to live my life, and I will continue to live my life the way I always have done, which is to continue, you know, taking every day as it comes, to try and do good, to try and move forward, to try and learn from all of the experiences that I've gone through to, you know, hopefully become a better person, to hopefully become a better doctor, and that's really all that I can That's really, I think, all that anyone can say, because life isn't perfect. Things don't always work out perfectly, but I really believe that if you've got good intention in your heart, and if you have nothing but a hope of goodness for others, I think that people see that and people realise that. So, although it's, as I said earlier, it can be painful to read negative things that are written about you. The people that really matter know who you are, or know who I am, and most importantly, I know what I'm about, and what I've always tried to do to help people and to live my life in a good way.